consultant at Shankar Nethralaya, Chennai. We are very, very grateful to him for giving us his time and for giving this presentation for the benefit of the postgraduates. We are also very grateful to Dr. Vikas Khetan, who is with us to be moderating the session today. We are also very blessed and grateful that Dr. Jyotirmay Biswas is with us, and we'll take some tips from him in the end also. A very warm welcome to Dr. Krishna Kumar sir, and we would like to request you to please make your presentation on ocular histopathology. Ocular pathology.
You are able to see, sir?
You are seeing the full screen. You make it full screen. Now I am able to see.
Yes, sir. I am starting. Thanks a lot, sir, for the opportunity. I thank Dr. Vikas Khetan also. Let us go with the class. I always acknowledge my teacher and my mentor, Professor Narsingh Rao. Without sir's teaching, I would have been not here today. I also thank Dr. Jyotirmay Biswas because he gave me an opportunity in 1998 to join the lab as his assistant. Now we have crossed 20 years. So far, by the grace of God, we are not fought like husband and wife. We are we are living together. I absolutely know. I am very pleasure to work with JB sir, and not for Chief Dr. Badrinath sir to call me and select me for job after my MD pathology. I am very grateful to our beloved Chief and our Chairman Dr. Badrinath sir. With this, we'll just go in a systematic way. Cornea. For the fellows, see whether you can label all the parts of cornea. You can see the arrows. I'll wait for a few seconds. Now see the answer. The cornea is multi-layered. It has got epithelium, Bowman's membrane, stroma, Descemet's membrane, and endothelial cells. It does not have blood vessels. It has got nerves, and various diseases can affect the various portions of the cornea, from infection to degenerations to dystrophy. Usually, textbooks tell there are no tumors in cornea, but ocular surface neoplasias can have transcorneal spread. Now, coming to the question, can you all identify what is the corneal problem and what is the stain? You see the corneal photograph and the special stain has been done. So please identify the dystrophy, whether it is epithelial or granular or macular or lattice. The answer is macular corneal dystrophy. The stain that has been done is a mucin stain. There are two types of stains. We can do an Alcian blue stain or a colloidal iron stain, where that picks up the eosinophilic or the bluish material between the stromal keratocytes, usually in the superficial portion of the corneal stroma. Now, the next question 3, can you identify the dystrophy? What dystrophy it is? Once again, you find the questions. We'll see the answer. This is a very beautiful stain for amyloid, where we have done the polarizer and shows apple green birefringence. This is lattice corneal dystrophy. This is stain for amyloid. Then, once again, one more dystrophy. What dystrophy you think? Can you see? There are 5 questions here. This is going to be the granular dystrophy of the cornea. This is trichrome stain. You get 3 colors. You get a bluish corneal stroma, you get a pinkish brick red color, and the nuclei stains bluish black. This is the hyaline material, which is very diagnostic of granular corneal dystrophy. And there are many 2 types. Could be a superficial granular dystrophy or a deep stromal dystrophy. You please read from your ophthalmology textbooks. Then, what do you think this is? This is portion of cornea showing the stroma, the Descemet's membrane. Something is wrong here. What do you think this is? Let us see the answer. This is going to be Fuchs dystrophy of the cornea. Here you find the Descemet's membrane is very much thickened. You find guttata, and the endothelial cells are atrophic or absent here. Next, can you identify the corneal problem? Is it a bacterial keratitis or virus or fungus or leprosy or none of the above? You find cornea showing a ring infiltrate, and you find these multiple structures in the corneal stroma. What do you think this is? None of the above. This is very diagnostic of acanthamoeba keratitis. Acanthamoeba keratitis is very, very common after contact lens. So whenever you see this ring infiltrate, one of the important differential diagnosis is acanthamoeba keratitis. Any special stains? Yes, you can do a trichrome stain, you can do a GMS stain to pick up these organisms. Next, now coming to the conjunctiva. This is the normal conjunctival epithelium showing the goblet cells and the substantial propia showing the stroma. So the most common thing you see in the conjunctiva is ocular surface squamous neoplasia. What happens? The conjunctival epithelium usually contains goblet cells, is replaced with multiple layers of epithelial cells which show keratosis and atypia. And there are grades in this. This could be mild ocular surface, mild dysplasia, moderate dysplasia, or severe dysplasia. Here you find moderate dysplasia, multiple layers of epithelial cells. This is ocular surface squamous neoplasia. Now, this is Vikas Khetan, just for a change. Myself and Vikas Khetan at Uganda. I think Vikas Khetan had a wonderful, gave me a wonderful opportunity to go to Uganda and teach, seek the country and discuss with the ophthalmologist about eye pathology. And now come to lid. Lid, what do you think is the lid swelling? There are four answers. Is it lipogranuloma or pyogenic granuloma, lipoma or tuberculosis? The answer is lipogranuloma or chalazion. What is that? It is, you find a central lipid vacuole, you find a granuloma, and you find a Langhan type giant cells. And you find these are all mixed inflammatory cells. This is lipogranuloma, which is very diagnostic of chalazion. Okay, what do you think this is? Is it lipogranuloma or is it pyogenic granuloma or tuberculosis? The answer is pyogenic granuloma. Now, the next question for you is, does in pyogenic granuloma, do you see any infection? You see bacteria or fungus or acid-fast bacillus or no, nothing? The correct answer is, usually, even though the term is pyogenic granuloma, it is negative for the infective organism. It is a reaction pattern, that is pyogenic granuloma. Okay, histopathology, you find the epithelium is flattened, multiple lobules of capillary type blood vessels are seen, and you can find a lot of mixed inflammatory cells. This is very diagnostic of pyogenic granuloma. You find at higher magnification, you find the capillaries and you find the blood vessels and the mixed inflammatory cells. Okay, now this is something you must know because this can be seen. What do you think this is? A man with HIV infection has got this pyogenic granuloma like lesions in the eyebrow. Is it chalazion, Kaposi sarcoma, or bacillary angiomatosis? The answer is bacillary angiomatosis. Kaposi sarcoma we don't see in India, but bacillary angiomatosis is an infection caused by Bartonella encellae. It mimics pyogenic granuloma. Why you must know this? Because this can be seen post-transplant where immunosuppression is given. And here you find histopathology, you find multiple capillaries and inflammatory cells. And you can find this eosinophilic clumps, this is bacteria. And this responds well to antibiotics like clarithromycin or doxycycline. So whenever you find pyogenic granuloma-like lesions in transplant or immunosuppression, biopsy is mandatory to rule out bacillary angiomatosis. Then what is this? Multiple yellowish flocks in the lid. Is it chalazion or xanthelasma? What are xanthogranuloma? The answer is both. Both xanthelasma and xanthogranuloma can have this pattern. Biopsy is mandatory and you must do lipid profile because both xanthelasma, xanthomas and xanthogranulomas can have this pattern and the treatment is slightly different for each of these things. What are these cells? These cells are predominantly seen in xanthomas. These are what? Are they foamy macrophages, neutrophils, eosinophils or lymphocytes? The answer is these are foamy macrophages. The histiocytes are filled with lipid material, so they appear foamy. This is commonly seen in xanthomas. What is this? This cell is a single large cell. is commonly seen in xanthogranuloma. Is it foamy macrophage? Is it a neutrophil? Is it a two-tone giant cell or lymphocyte? The correct answer is two-tone giant cell. Yes, this is a two-tone giant cell. You find a ring of nuclei with lipid material. This is very, very diagnostic of xanthogranuloma. In fact, xanthogranuloma diagnosis should be made only when you see this two-tone giant cell. You don't see two-tone giant cell, then it becomes a xanthoma. Okay, what are these cells once again? I know all of you know this. This is two-tone giant cells. Yes, you are correct. Now, two-tone giant cells are a type of multinucleated giant cell seen in lesions with high lipid content such as fat necrosis, xanthomas and xanthelasma, and also xanthogranulomas. Why? And this is Dr. Jennifer Picarsi. She is a very eminent pediatrician and pediatric pathologist. She has done wonderful work on histiocytic disorder, and her team has come out with targeted therapy and molecular classification of histiocytic disorders. Now, whenever you see histiocytic disorder like Langhan histiocytosis or xanthogranuloma, there is personalized medicine has got a very important role. She has done RNA sequencing and identified many mutations and pathways so that there are targeted therapy for histiocytic disorders. So she is Jennifer Picarsi. What are these giant cells? You find the arrows. These are multiple types of giant cells. You find the nucleus is at one side, like the shape of a U, or the foamy macrophages, Langhan type giant cell, foreign body giant cell, or two-tone giant cell. The correct answer is Langhan's type giant cell. So, what is this? This is a special stain done for the previous case. Are they gram stain, or is it stain for fungus, or Giemsa stain, or acid fast stain? This is acid fast stain for tuberculosis. Whenever you find Langhan's giant cell in a granuloma, you have to do acid fast stain. And also, like somebody like Dr. JB sir always likes PCR for tuberculosis. Or also do a PCR because that also supports the diagnosis. Sometimes no, the AFB we cannot see, it may be scanty, but PCR is more sensitive and specific. Am I correct, sir?
Yes.
Yes, sir.
Very
Thank you.
But if once you see it, you don't need PCR.
Yes, sir. Yes, sir. Next is you see one more granuloma you find. Is it not? You find a lot of granulomas. And what is this? You see some filamentous-like structure. And you see some pinkish stain. Is it a gram stain? Is it a PA stain? Or an acid fast stain? This is PA stain. So, to identify organisms, there are multiple stains. Usually, gram stain is done for bacteria. We can get information whether it is gram positive or gram negative. PA stain and GM stain is good for fungus. Acid fast stain is good for tuberculosis. So here, this is a PA stain showing the septate fungal filaments. What is this? This is a patient having a corneal flap, conjunctival flap, which got infected. And some special stain has been done. You find a green background and you find multiple black structures. What is this stain? Is it a GM stain for fungus, or a gram stain, or a Giemsa stain, or a von Kosa stain showing calcium artifact? The correct answer is GM stain. This was Candida. So GM stain is a special stain which can be done on the paraffin sections to document the fungus. This is a very, very useful stain in histopathology. But the drawback is it takes around 3 to 4 hours to do the stain. So this cannot be done in emergency situation. Next is, so far we are discussed something on granuloma. Granuloma is one of the hallmark of chronic inflammation. Granuloma can have necrosis. So these are some of the conditions. So which condition you can see granuloma? Chalazion, TB, fungus, sarcoidosis, persistent suture material, xanthogranuloma, vaginous leprosy. So where do you see granuloma? Granuloma can be seen in all the conditions. So whenever you see granuloma, it is a reaction pattern. As a pathologist, we have to know what is the problem. We have to clinically correlate, do special stains, or investigate like PCR, or do biochemical tests like ANCA, or stains for leprosy to know what is the clinical situation. For example, granulomas can undergo necrosis. So, see that this is a granuloma with a necrosis. This granuloma with necrosis can be seen in TB, fungus, and also in Wegener's granulomatosis. So, whenever a granuloma is in necrosis, these are the three top conditions which the pathologist thinks of. But this is a caseous necrosis, so this is tuberculosis. You find the central caseous necrosis, you find the U-shaped Langhan type giant cell, you find the macrophages, epithelioid cells, and inflammatory cells. This is tuberculosis. Now, this is granuloma. You see the giant cells showing necrosis. And here you find a GMS stain. Why you GMS stain? You see this filament here. So this is fungus. So this is a fungal granuloma with necrosis showing the filaments. Then what is this lid lesion? Multiple papular lesions are seen in the upper lid, whether it is a papilloma or OSSN or molluscum or viral wart. We'll see what it is. This is a viral wart. Viral warts are commonly seen in children and also in adults. What histopathology, which is very diagnostic of viral wart, is the coilocytic cells, the vacuolated cells in the superficial portion of the epidermis. This is due to the human papilloma virus. There is oncogenic strain and non-oncogenic strain. What is this? In another case, lid lesion, you find an umbilicated papule. These are the four conditions: papilloma, OSSN, molluscum, and viral wart. What do you think is the answer? Yes, you are all correct. The correct answer is molluscum contagiosum, Dr. JB's favorite topic.
Okay.
and I think sir has published a lot. Yes, sir. Whenever you see multiple molluscum contagiosum in a child or adult, you must do some testing. These are the four testing: HIV testing, CD4, CD8 ratio, globulins, and ESR. I think all the testing you must do, because immunodeficiency and HIV infections can produce multiple molluscum contagiosum. I think JB sir has got a paper in American Journal of Ophthalmology where 1,000 cases of consecutive cases of HIV and ophthalmic findings. He has published many cases. So whenever you see multiple molluscum contagiosum, please think of underlying immunodeficiency. Please don't, please rule out HIV infection in children. These are the histopathology. Histopathology, you find the molluscum bodies. These are intracytoplasmic pinkish inclusion bodies, which are seen in molluscum contagiosum. The confusing technical term for this is Anderson-Patterson bodies, but don't worry about that. Molluscum bodies. That make it. Let us make it life simple. Then next we go to the lid. This is a lid. You find an ulcer. Lid ulcer. Is it a melanoma? Is it a Bowen's? Is it a basal cell carcinoma or a squamous cell carcinoma? The answer is yes. All of you are correct. This is basal cell carcinoma. The common cause for lower lid ulceration is basal cell carcinoma. That is the first diagnosis in elderly people. Okay. What do you see in histopathology? You find epidermis. You find the surface epidermis is seen. You find tumor lobules. And these are the basaloid tumor cells with peripheral phallisading. You find the peripheral cells are tall, columnar, and the central cells are small, cuboidal. And this is coming from the lower portion of the epidermis. And this is the dermis. That's why it is basal cell carcinoma. And here you find tumor lobules, and you find small cracking artifact. This is very, very diagnostic clue for basal cell carcinoma, because trichoepitheliomas and other benign tumors may not show this cracking artifact. Here, once again, higher magnification, you find a higher magnification, you find the tumor lobules, you find that atypical mitosis, you find this cracking artifact. So this is basal cell carcinoma. Next, we'll learn something more about basal cell carcinoma. Come on, all of you must, whenever you see basal cell carcinoma, you must know, is there low risk basal cell carcinoma? What, sir? Basal cell carcinoma per se is a problem. Is there low risk and high risk? Yes. This is 2019. They have classified basal cell carcinoma into low risk. What are the low risk BCC? Yes, nodular BCC, superficial spreading BCC, and infundibulocystic BCC are low risk BCC. The chance for recurrence is less after biopsy or surgery. Then what are high risk BCC? Yes, Morphe type, infiltrating BCC, and micronodular BCC, and I left this basosquamous cell BCC or high risk basal cell carcinoma. The chances of recurrence is very, very high. This is the 2019 classification where they classify basal cell carcinoma into low risk and high risk. See, low risk, nodular, superficial, pigmented, infundibulocystic, fibroepithelial type. High risk, basosquamous cell carcinoma, sclerosing or Morphe, infiltrating, basal cell carcinoma with a sarcomatoid differentiation, and micronodular. So next time you go to exam, they ask about basal cell carcinoma. You must remember whether you are low risk or high risk. In your practice also, when a pathologist tells basal cell carcinoma, don't stop. Ask them under which category does it belong. Does it low risk BCC or high risk BCC? Because the treatment and approach is slightly different. Now, next, see, you find something here from the lid. What it is it a papilloma or bubons or basal cell carcinoma or squamous cell carcinoma? Let us see what is the answer. Yes, this is papilloma. Here you find beautiful histopathology. You find finger-like projections with multi-layered epithelium, and you find a fibrovascular pore. This is exophytic squamous papilloma. Squamous papillomas are usually benign, but sometimes they may show dysplasia. Okay. And this is another commonly thing you see in your practice. Elderly people having these pigmented lesions. So you are concerned whether it is a papilloma or seborrheic keratosis, BCC or melanoma. Whenever you see this, common is seborrheic keratosis. Seborrheic keratosis is a benign tumor. It comes due to aging and photo damage. You find thickened epidermis with multiple keratin cysts because of trapping of the keratin. There is usually no atypia. This must not be mistaken for basal cell carcinoma or melanoma. What is this? Elderly man with a nodule in the upper lid with a loss of eyelashes. What it is? Is it papilloma, seborrheic keratosis, BCC or SGC? Whenever you see like this with a loss of eyelashes, always think of sebaceous gland carcinoma. It's very, very dangerous tumor. And this is the recently they have classified this into ocular sebaceous gland carcinoma and extraocular sebaceous gland carcinoma. Why? Because ocular sebaceous gland carcinoma, majority of them are poorly differentiated and they're aggressive, and there is no association with Muir-Torre syndrome. People with Muir-Torre syndrome are prone for multiple systemic malignancies. Extraocular, anything other than periocular area, they are well differentiated, usually good prognosis, but they can be associated with Muir-Torre syndrome. So this is an exam point. So when they ask you ocular sebaceous gland carcinoma, is there any chance for Muir-Torre syndrome? You must tell no. That's a very, very important point. This is another classification where from MD Anderson, the Beta Ismaili group had published in Clinical Cancer Research last year, and they are classifying sebaceous gland carcinoma ocular adnexal type into two types, type 1 and type 2. Type 1 is seen in older patients, increased local recurrence, and there is mutation, P53, RB1 mutation is high, and the human papillomavirus is negative. Type 2 is younger patients, less of local recurrence. There is wild type mutation in P53, and they are telling human papillomavirus risk is positive. So this study, other people have to do the study to look for human papillomavirus and sebaceous gland carcinoma. But this is the classification which has come from Beta Ismaili type 1 and type 2 sebaceous gland carcinoma. Yes, see the histopathology. You find the surface ulceration and you find tumor lobules infiltrating into the dermis. And you had higher magnification. You find cells having a lot of vacuolation, which means lipidization. You find a lot of pleomorphism, tumor giant cells, and necrotic cells. And you find these vacuolated structures that is suggestive of sebaceous gland carcinoma. Sometimes the tumor lobules can also show central necrosis. This is called as comedonecrosis, which you see in breast carcinoma. This is because of rapid growth of tumor and central hypoxia. Here you find the tumor cell showing beautifully. You find this nucleus, you find this peripheral lipidization. This is very, very important. And immunohistochemistry, epithelial membrane antigen is positive. In this, you find this bubbly pattern of EMA in cytoplasm. This is an important marker. EMA can be done on permanent section. If on the frozen samples, you can do oil overhead staining. That stains lipid, it is cytoplasmic, it is positive. That also gives a clue, it is sebaceous gland carcinoma. However, in poorly differentiated tumors, lipid stains can be negative. You must be very, very careful. What is this? This person has got Stevens-Johnson syndrome, cicatricial pemphigoid. Is it intraepithelial spread of basal cell carcinoma or sebaceous gland carcinoma? Whenever you see like this, always please rule out intraepithelial spread of sebaceous gland carcinoma. Unilateral diffuse thickening of the eyelid is the second most frequent presentation of sebaceous gland carcinoma. It can present as recurrent blepharoconjunctivitis. It can extend into the fornix, conjunctiva, and even into the cornea. And you find this is intraepithelial spread of sebaceous gland carcinoma. This is called pagetoid spread of tumor cells. And this is a panel of markers which will be helpful for the pathologist. Usually, sebaceous gland carcinomas are EMA positive, adipofilin positive, P53 positive. Basal cell carcinoma is BER-EP4 positive. So, whenever there is a doubt, we are looking at basal cell carcinoma or sebaceous, we can do BER-EP4. And if poorly differentiated sebaceous gland carcinomas can be mistaken for squamous cell carcinomas. So you can do a combination of BER-EP4. BER-EP4 is usually negative in squamous cell carcinomas, and adipofilin is also negative. So these markers are helpful because for some treatment like radiotherapy and all those things to be decided based on the markers. So kindly on these things can be done on the permanent section. So very, very important whenever you have a poorly differentiated sebaceous gland carcinomas, we pathologists make use of a panel of markers to confirm the diagnosis. This is Dr. J.B. sir's favorite tumor. This is a eyebrow nodule. And this is pilomatrixoma. You find shadow cells, basaloid cells. These are called as ghost-like cells. This is commonly seen a benign tumor called as pilomatrixoma. Next is, this is a new entity which has come in 2019 called as endocrine mucin producing sweat gland carcinoma. Can mimic a cyst. You may mistake it for an apocrine cyst and leave it away and excise it or not sent to pathology department, but be careful whenever you see something like a cystic structure mimicking an acrine cyst or apocrine cyst. This is endocrine mucin secreting carcinoma. This is in situ endocrine mucin secreting carcinoma, and it becomes an invasive mucinous carcinoma. That's what they tell. It has got it is deep in the dermis with the papillary structures and the mucin. And it shows markers. It shows markers like synaptophysin. Synaptophysin is a neuroendocrine marker. GATA3, cytokeratin positive. Whenever you see this sort of pattern of synaptophysin positivity and GATA3 positivity, think in terms of endocrine. Remember this. Endocrine mucin producing sweat gland carcinoma can mimic a simple cyst. So please submit any sample to histopathology department. That's very important. Then come to intraocular tumors. This is once again, I must tell, thanks to Dr. Vikas Khetan. This is Dr. Keith Waddell we saw him in Roraro Eye Hospital, a very, very great person. He has sacrificed his entire life for management of retinoblastoma kids and all these things. I think one of these days, Vikas Khetan will share his trip to Uganda and how it was a great opportunity for people like me to meet a great person like this, Dr. Keith Waddell. And what is this? This is an eyeball which has been cut. What is this intraocular lesion? Is it you find the cornea, you find the optic nerve here? Is it amelanotic melanoma, Port's disease, retinoblastoma, endophthalmitis? This will be always a common exam question in the DNB or DO. They may show you a photograph like this and ask them, what do you think this is? This is retinoblastoma. Yes, you are all correct. Chalky whitish lesion arising from the retina and retina showing detachment. This is retinoblastoma. Great. And you must know about this person, Dr. Patricia Brios, good friend of Dr. Vikas Khetan, and she was a key person who, along with Murali Chintakumpala and Vikas Khetan is also there in the team. They brought about this uniform grossing. See, some 10 years back, 15 years back, we used to cut retinoblastoma into 2 or 3 blocks and report it. But after this international retinoblastoma study, where they came out with protocols to gross the eyeballs. They said, hey, you have to cut the eyeball into lateral calots, central calots, and the lateral calot into multiple blood flow sections. So by this, I think we are able to pick up more of invasion of choroid. I think Vikas Khetan also has a paper where he said, when he compared the studies before this protocol and after this protocol, there was more than 10 or 15% incidence where he picked up invasion of choroid. So universally, globally, whenever any retinoblastoma tumor grossing is done, we have to report like this. How does it come? It comes like this. So you have a central calot. This is from Nethralaya. You have a central calot. You have a central calot. You have a lateral calot, and blood flow sections. And so we have to see around 22 sections. This is the surgical end of optic nerve. So the retinoblastoma reporting, we see around 18 to 22 slides to make a report according to this international retinoblastoma staging working group protocols. So whenever you exam the ask, you have to mention this. The retinoblastoma is crossed according to International Retinoblastoma Staging Working Group Protocol guidelines. You find central cut, lateral cut, and the lateral calot is made into multiple blood flow sections. So you study series of sections to tell about the pathology staging. You find here glass slide containing eyeball showing a corneal side, optic nerve side, scleral side. This is retinoblastoma arising from the retina. This choroid is detached artifactly. This shows diffuse retinoblastoma. You find cornea, iris, lens. You find a retina showing, I think Vikas Khetan has seen a couple of cases, and I think he's published it on this is the optic nerve. You find this is intraretinal retinoblastoma. In fact, first case, I was not able to see retinoblastoma. Then Vikas Khetan came and told me this is intraretinal retinoblastoma. So this is very deceptive and can mimic as masquerade syndrome. And this is higher magnification. You find tumor lobules around the central blood vessels. These are the viable cells. These are the arrow shows the necrotic cells. Low magnification, you find a combination of viable tumor cells and necrotic tumor cells in retinoblastoma. This is common because of the hypoxia and vascularization. Here you find extensive calcification. Calcification can be seen even before chemotherapy, but you find sometimes the entire tumor regressing and calcification post-chemotherapy is also seen. These are the rosettes. See, this is central neuropil with rosettes. This is seen in poorly differentiated retinoblastomas. This is flexnum intestinal rosette. See the central thing, flower-like structure with the central lumen. Some years back, we used to have more importance to differentiation, but now people don't give much importance to differentiation.
Yes.
This is, I must tell, Professor Hans Gross-Nicholas, a very eminent ophthalmic pathologist at Emory Center, and this 2018-19 Armed Force Fascicle or the WHO Fascicle in ocular tumors. He is the chairperson for that. It's a wonderful book. I think all the students must go through this book. It is not very expensive. And he brought the concept of anaplasia and retinoblastoma. He says this is tumor anaplasia. Here you find the tumor cells are elongated. And he says anaplasia is a very, very important component of prognosis. Tumors with severe anaplasia, it adds to the prognostication stage. That's what he tells. And then you find here, this is focal RP invasion, retinoblastoma tumor cells. This is a choroid sclera. Tumor cells are invading the retinal pigment epithelium and trying to enter choroid, but still not entered the choroid. Here you find the tumor cells. You find this whitish thing here. This is diffuse choroidal invasion. Whenever you see choroid, is it diffuse or focal? Here we tell diffuse invasion of choroid more than 3 millimeters. That comes under high-risk histopathology. Once again, you find sclera. You find the RPE. You find tumor cells here. You find the posterior segment. you find the tumor cells are fully invading the choroid, more than 3 millimeters. And if they touch the sclera also, it means it is high-risk retinoblastoma. And then here you find a section of eyeball, optic nerve, showing the tumor cells invading the laminar portion and post-laminar portion. But here you find the remaining areas are free. This is post-laminar invasion of the optic nerve. So when we see, we have to give to the pathologist, to the ophthalmologist, this is involving 2 millimeters of the post-laminar portion, but the remaining is free. So they will decide what to do, whether it is high risk or low risk. This is the surgical end of the optic nerve. Here you find the tumor is completely, the optic nerve surgical end is completely free of tumor. So the reporting must have all these things, component. Now this is another important case. What is this? Elderly person having these fundus lesions, whether it is retinitis, intraocular tuberculosis, toxoplasmosis, or lymphoma. I know all of you know or got the answer. Yes, it is intraocular lymphoma. Correct. Now, this is images from histopathology Sankara Nethralaya. If a large tumor cells forming clumps with high nucleocytoplasmic ratio and if a lot of necrotic background, whenever you find atypical lymphoid cells with high nucleocytoplasmic ratio in a necrotic background, we always must rule out intraocular lymphomas. And I must tell about Professor Sarah Copeland, good friend of Dr. Vikas Khetan, and she is a very eminent oncologist and ocular pathologist who brought this concept of MID mutation to diagnose, to increase the detection rate of B-cell lymphoma. And based on madam's inputs, we optimized MID88 at Sankara Nethralaya, and this is our own data. And you see this first graph, you find green arrow and red arrow. That is intraocular lymphoma, is mutation MID88L265P. 2, it is a CMV retinitis, you find only green arrows. Whenever you find these sort of peaks, double peaks and single peak. Double peak means it's lymphoma, single peak means it is not lymphoma. And so MID88 must be routinely used to confirm or diagnose lymphoma. Sometimes it is a very diagnostic dilemma. And this is going to come in IJO, it has come. Thanks to Vikas Khetan, Dr. Biswas, and my students Sandhya Narasimhan and my colleague Dr. Soumya Parameshwaran, who are very, very important. And what is this? This is once again an eyeball, cornea, and you find some pigmented mass coming from here. What do you think? Is it medulloepithelioma, retinoblastoma, lymphoma, or choroidal melanoma? Where is the mass? It is coming beneath the retina. So since it comes from the choroid, it is choroidal melanoma. See, this section shows cornea, lens. You find a pigmented, you find a tumor coming from the choroid, causing secondary retinal detachment and optic nerve. The retina is just deflected because of the tumor. Once again, you find cornea, lens. You find the tumor, pigmented tumor, partially coming from the ciliary body and choroid. This is ciliochoroidal melanoma. Yes, these are cell types. These are the spindle cells, and these are the epithelioid cells. If the tumor contains more of spindle cells, we call spindle melanoma. If it contains more of epithelioid cells, we call epithelioid melanoma. If it contains both, we call it as mixed cell melanoma. And so I must read about this excellent article in IJO, where Swati Kalki, along with Shields, has published prognostic markers in melanoma. They talk from the clinical features of age, large tumor diameter, and they talk about histopathological features like cell type, mitotic activity, microvascular density, microvascular loops, tumor infiltrating lymphocytes, macrophages, HLA expression, and insulin growth factor receptor. And just to show, this is an excellent work done by a very senior pathologist, Robert Folberg, friend of Dr. Biswas. He brought this concept of loops and networks in melanoma. This is PA10. You find the melanoma cells are all trapped by these loops. Initially, they thought these are blood vessels, but now we know these are all extracellular matrix, which is generated by the tumor to provide the nutrition to the tumor. So if you find these loops and networks, it is a bad prognosis. But yet the thing got revolutionized by Professor Will Harbour. He was initially in Baskin Farmer. I think now he is in is in some Sylvester Comprehensive Cancer Center, and he brought the concept of gene expression profiling in melanoma and classified melanomas into two groups, class 1 and class 2. Then Dr. Martin Jagger and others from Europe did a wonderful lot of work on chromosomal aberrations and brought the concept of monosomy 3 and disomy in melanoma. So there is a group, chromosomal aberrations by Martin Jagger group, and gene expression profiling by Will Harbour. They also are used to prognosticate melanomas. So this is by Will Harbour group. Initially they put only class 1, class 2, then they subdivided class 1A, class 1B. Class 1A, very low risk with a 2% chance for eye cancer spreading. Class 1B, 21% chance. Class 2, high risk with the metastasis. But this is once they see the melanoma, FNAB is done, and the tumor sample is sent it to Castle Diagnostics in Seattle, and they give the gene expression profiling. And this facility is not available for the Asian Indians because this data has been validated with the Caucasian population. Then we have this Dr. Shields group has validated the TCGA classification of the chromosomal aberration. It has been published in IJO, and please read this. According to their study, they classify they classify based on TCGA into 4 groups, A, B, C, D. See, based on chromosome 3 and chromosome 8. So chromosome 3, disomy 3 is the disomy 8q favorable. Disomy 3 and 8q gain, it is late metastasis. Monosomy 3 and 8q gain, unfavorable. Monosomy 3 and 8q gain, multiple, unfavorable. So this is the current classification, current methodology where people in US have started using the chromosomal aberration based on TCGA to classify melanoma. Initially, we had 2 groups, class 1, class 2, then class 1A, class 1B, class 2. Now, class A, B, C, D based on the TCGA. This is, please read the IJO article. Now, what is this? Is it melanoma, retinoblastoma, drusen? This is the retinal layers, this is the RPE. You find some pinkish material beneath the RPE. This is drusen. This is our drusen. Come to lacrimal gland tumors. What is this? So you find a beautiful pattern, but very, whether it is adenoid cystic tumor or pleomorphic adenoma, dacryoadenitis or ductal adenocarcinoma. I know all of you will know. Yes, this is adenoid cystic carcinoma of the lacrimal gland, a very dangerous malignancy. This is the cribriform pattern of the adenoid cystic carcinoma. This spreads, and you must know this. What is the common molecular alteration in adenoid cystic carcinoma? It may be new to you, but learn. It is MYB NFIB fusion. Most of the adenoid cystic carcinomas have reported this fusion gene. We don't know whether in future there could be a target therapy for this currently at this stage. Yes, a lacrimal gland adenoid cystic carcinoma is resected. Which of the following statement is true? It has got an excellent prognosis. It is characterized by point mutation involving MYB gene. Solid pattern is associated with adverse clinical outcome. Perineural invasion is bad. The answer is yes. Solid pattern in adenoid cystic carcinoma is bad, and perineural invasion is also bad. Then what is this? This is another tumor of the lacrimal gland, whether it is adenoid cystic, pleomorphic adenoma, dacryoadenitis, ductal carcinoma. This is ductal adenocarcinoma of the lacrimal gland. This you must know this because this has got slightly a better prognosis than the adenoid cystic carcinoma. So it is very important for us to subtype the malignant tumors of the lacrimal gland. What is this? This is very Dr. Biswas likes it. This is something in the lacrimal gland, whether it's a sarcoidal granuloma or pleomorphic adenoma, dacryoadenitis or tumor. The answer is sarcoidal granulomas. Granulomas can also come in lacrimal gland. You can get tuberculosis of the lacrimal gland, but sarcoidosis is very common in the lacrimal gland. So you need to investigate the patient, take X-ray chest, do some serum biochemical parameters before you label it as sarcoidosis. Sarcoidal granuloma does not mean sarcoidosis. You have to investigate. Now come to lacrimal sac. What is this? It looks very scary, multiple round structures like UFO looking at you. Is this tumor? Is it rhinosporidiosis? Is it dactylocystitis or multiple lymphoma? My God, what is this? This is rhinosporidiosis. Rhinosporidiosis of the lacrimal sac. We see quite frequently. We see this in a year. We see it in 1 or 2 cases. We see cases from Kerala. From Kerala, we see this sort of rhinosporidiosis. Maybe the habit of people having bathed in the river. Then this is rhinosporidiosis of the lacrimal sac, showing it is filled with this cystic structures and sporangia and spores. Yes, you can also get a blue tumor of the lacrimal sac. What do you think this is? This is multiple lymphomas because of associated lymphoid lymphoma of the lacrimal sac. These are atypical lymphoid cells, and this is CD20 positive. Most of the multiple lymphomas are B lymphomas. Yes, this is Professor Ralph Eagle. He's the director of ocular pathology. You know one secret about Professor Ralph Eagle? Usually when he comes to meeting, Professor Ralph Eagle always has got the tie. This is what Vikas Khetan told me. You will see retinoblastoma images, melanoma images. So you will put a pathological tie. That's what I'm told. See, Professor Ralph Eagle. Now he has also got mask, looking at us and telling, hey guys, all of you put your mask when you go outside. And this is his new colleague, Tiana Millman, who has recently joined the Wills Eye faculty. Now come to orbit. Yes. This is a rapidly growing orbital mass in the child. What do you think? Could it be a rhabdomyosarcoma? Yes. Lymphoma? Yes. Scleroma? Yes, yes, yes. Tuberculosis? Yes. All these things are rapidly growing. But this is rhabdomyosarcoma. This is embryonal rhabdomyosarcomas are common in the orbit. And these are the rhabdomyoblasts. These are well differentiated large cells. See this with prominent, with nucleoli. Okay. Then this is another type of rhabdomyosarcoma is that there is alveolar rhabdomyosarcoma, and this is myogenin is a muscle marker. Nuclear positivity is seen more in alveolar rhabdomyosarcoma. Why must we worry about embryonal rhabdomyosarcoma and alveolar rhabdomyosarcoma? I will tell you why. Because now tell me, which immunostaining has been described as more in alveolar rhabdomyosarcoma? I know all of you know the answer. It is myogenin. Okay. Which of the, these are new points. Which of the following molecular aberrations can be seen in alveolar rhabdomyosarcoma? Is it COL1 or SS18 or Ewing sarcoma or FOXO1 or PAX3? The answer is FOXO1, PAX7. Why you must know this? Because there could be overlapping morphological features between embryonal rhabdomyosarcoma and alveolar rhabdomyosarcoma solid pattern. So it may be difficult from light microscopy to differentiate between embryonal rhabdomyosarcoma and alveolar rhabdomyosarcoma. So molecular analysis is very, very important. Furthermore, in children, when there is a fusion gene, PAX3 or PAX7, the prognosis is bad compared to rhabdomyosarcomas with no fusion gene. And if in fusion gene, fusion involving PAX3 has got a shorter survival than PAX7. In this way, for personalized medicine, studying this fusion genes is very, very important. Thanks a lot. This is myself in Uganda taking class to the ophthalmologist, eye pathology. I thank a lot for all of you listening, and Vikas Khetan and Dr. JB attending, and also the people from Patna giving me a talk. Now, any questions I am willing to take. Sir, you have to unmute, sir.
Remembering Dr. Narsingh Rao, who used to teach us the way you are teaching, the simple thing to start from the structure and slowly go to the advanced and research. This is wonderful.
Thank you, sir. Thank you, sir.
Dear Dr. Narsingh Rao, I am getting through you. Wonderful.
Thank you, sir.
The ophthalmologist will be in the exam, they will get the retinoblastoma. So should know that the optic nerve invasion, choroidal invasion, how to cut, and the braid lobe sections. These are the things you should tell.
Anybody there, sir? Nobody is opening. Anybody there?
No.
Vikas, you're there?
Yeah, I'm there. I'm there. So,
Sir, we can give the slides, sir. I can email the slides to you today or tomorrow. You can share with all the postgraduates so that I can make a PDF and send to them. So all of them can see the PDF and learn, sir. That also we can do. So that they can go through it again and again. It will be useful for them for the exams.
Sir, this presentation has been recorded, sir.
Okay,
and
good.
they will be able. It will be uploaded on YouTube also, sir. And they'll be able to see it again, sir.
Thank you, sir.
That's wonderful. That's wonderful.
Wonderful, sir.
It's very rarely you get an opportunity to listen to such presentations of involving whole part of the eye.
Yes, sir. Yes, sir. Worldwide postgraduates will be seeing this on YouTube, sir.
Okay.
Oh,
Vikas, you have any questions?
yeah, no, the only thing I will say is that from an ophthalmologist perspective, most people ignore ocular pathology a lot. So becoming an ophthalmologist, you don't need to know much of ocular pathology. If you know retinoblastoma, choroidal melanoma, basal cell carcinoma of the lids, squamous cell, rhabdomyosarcoma, I think you can easily pass your exams. But once you decide to do a fellowship, and if somebody wants to do ocular oncology, then this presentation is extremely, extremely important. Subtyping the different types of tumors, knowing what genetic mutations are taking place in different types of tumors, because personalized care is going to come. It's whether we like it or not, in the next 5-10 years, we will have a lot of these tumors being treated with personalized medicine. So thank you, KK sir. It was an excellent class. Though I think I will forget most of it right after I turn off the laptop. But the details with which you've gotten into different cases, showing both clinical picture and showing the pathology slides. Thank you very much.
And also showing the eminent pathologists globally, who are done contributed a lot.
Absolutely. Yeah.
Because all the ophthalmologists must know about Professor Ralph Eagle, Hans Gross-Nicholas, and what Shields has done, what Will Harbour has done.
Absolutely.
I think they have to know, because we stand on the giants and we learn things. What Professor Narsingrao has done to uveitis and eye pathology. I think it is the chance for me to tell about our teachers, the great people whom we have a chance to interact and learn from them.
Sure.
Sir, there is one question of what is the difference between rosettes and pseudo rosettes in RB, sir?
Sir, pseudo rosettes is something you see in a lobule, sir. When there is necrosis, there is a central blood vessel. The tumor cells are arranged around the central blood vessel. That is a pseudo rosette, sir. That is a pseudo rosette. Can I go back to the slide? I can tell them by the slides. Sir, I'll tell them by the slide. Are you able to see the slide?
Yeah, this is a pseudo rosette.
See, this is a pseudo rosette. You find a central blood vessel, you find viable tumor cells, and you find necrotic. This is a pseudo rosette. You find multiple pseudo rosettes here. But a real rosette is this. This is a rosette. This is a rosette.
Yes, sir. Thank you so much, sir. I'm deeply indebted to Dr. Krishna Kumar for this wonderful and amazing presentation, which for a very, very long time will be very, very helpful for all the postgraduates. I'm very grateful to Dr. Vikas Khetan for the moderation that he has done today. And we are very grateful to Dr. Jyotirmay Biswas, who was with us and his blessings is so important to us. I'm very grateful to Intas Pharma, Manish ji and Chandrasekhar ji for putting this presentation together. This presentation will be available for the postgraduates on YouTube also, so that they can see it later. We'll put up the link. Thank you so much, sir, once again, Dr. Krishna, for this wonderful presentation. We are very, very grateful to you, sir. Thank you so much.
Thank you, sir. Thank you, Dr. Vikas. Thank you, Jamie, sir.
Thank you.
Thank you. Thank you, everybody. So
Yes,
see you tomorrow.
Thank you so much. Thank you so much.